Okay, next up we have Dr. BREINHOLT, who earned his medical degree from University of Utah and then completed his pediatric residency at Baylor and Texas Children's, and he received additional training there in cardiomyopathy and cardiac transplant. He was the Director for Pediatric Cardiology Fellowship at Indiana University and currently serves as the Chief of Pediatric Cardiology at Children's Memorial Hermann Hospital. His talk will be on pulmonary atresia and VSD and Truncus Arteriosus.
Good morning. It's a pleasure to be here. Appreciate the organizers of the meeting inviting me to present to you today. Also wanted to say hello to our friends at the Hospital Zambrano in Monterrey, Mexico that are watching via the internet. Dr. Britton and Dr. Yanez and their team are watching, trying to learn, and want to welcome them also to this meeting. I'm a pediatric cardiologist and do pediatric interventional cardiology, but as a result tend to do a fair amount of adult congenital interventions in the cath lab, and I work very closely with Dr. Lin in that endeavor. Today I'd like to talk a little bit about some of the other cyanotic heart lesions of pulmonary atresia, ventricular septal defect, and Truncus Arteriosus. And to kind of start off, these are some numbers that a lot of people have seen, but I think importantly for this group is the understanding that as early as 2010, we were already seeing more adults with congenital heart disease than children due to the fact that they're surviving. And it's interesting that if you look in the city of Houston, there's about roughly 50 pediatric cardiologists, and there's probably about 6 or 7 adult congenital cardiologists. So we have fewer adult congenital dedicated cardiologists for a larger population than we have children, so it's certainly a great need and a need for focus, which is why many of us pediatric cardiologists remain invested in and work with them. Also important is that, and this is even old data, and I would expect that these numbers are going to continue to increase, that about 70% of children born with critical congenital heart disease are going to survive into adulthood. The main purpose for also bringing this slide this is kind of a history of some of the interventional advances, but importantly is to look at the advent of prostaglandin E, the medication that allows us actually time to assess these children, treat them, came about in 1973, so it actually after I was born, and allowed us to go from children that would become critically ill and would die without immediate and urgent intervention to be able to open up the ductus arteriosus to allow them to be stabilized and to allow some of the very surgeries and interventions that we can do today. So pulmonary atresia ventricular septal defect. It's considered a severe form of tetralogy Fallot, kind of the ultimate side of the spectrum of tetralogy. It's where the pulmonary valve orifice fails to develop. Pulmonary blood flow source is either via the ductus arteriosus or via major aortopulmonary collateral vessels, which I'll discuss later on. Typically, there's no murmur, so this is not patients that will have a very obvious clinical exam, and it will usually require the prostaglandins I mentioned earlier to survive due to severe cyanosis. And this kind of shows you a pictograph here's a normal heart, and you can start to see the abnormalities of this would be a malaligned ventricular septal defect that tends to be large, and then the other component being the absence of a patent pulmonary valve. So in order for pulmonary blood flow arises via the ductus arteriosus here, and this is where you see the blue blood crossing right to left into the left side, and then going into the pulmonary arteries to provide blood flow there, and then get more oxygen to maintain this part red for that further mixing. Pulmonary atresia represents 2.5 to 3.4% of all congenital cardiac malformations, which ends up being about 0.07% per 1,000 live births. So it's a very, very rare disease, but certainly we see it all the time, so it seems more common. It's slightly more prevalent in males than females. As already been mentioned with tetralogy, it is often associated with microdeletion of 22q11 or DeGeorge syndrome. Also seen in Vater or Vactral syndrome, where there's also vertebral anomalies anal atresia, T fistula, and renal anomalies. Can be seen in Alagille syndrome and also in trisomy 21 or Down syndrome. There are also environmental factors that have been implicated. Pulmonary overcirculation is one of the things that we begin to see as the pulmonary vascular resistance declines, is of course in the setting of having the ductus arteriosus maintained patent. On physical exam, they will start to develop cyanosis. They'll have a wide pulse pressure, which is caused by having this diastolic runoff into the pulmonary arteries through the ductus arteriosus. There's no valve, so you have this greater area in which blood can flow, and so their pulse pressure tends to be widened and have bounding pulses, and they tend to have a hyperdynamic precordium. On physical exam, they'll have a single S2, since S2 is representative of your aorta and pulmonary valves closing. You're not going to hear a second a splitting of S2 because there's no second valve. There tends to be a continuous or systolic murmur of the left upper sternal border, which is going to be either more prominent due to the ductus arteriosus constricting prior to the initiation of prostaglandins, or due to increased flow as pulmonary vascular resistance drops. The way in which this is treated is often initially with the traditional method is by closure of the ductus arteriosus and placement of a shunt, usually a Blalock-Taussig type shunt. Sometimes if you have very hypoplastic pulmonary arteries, some will place a central shunt, which will come from the ascending aorta directly into the pulmonary arteries. And then in some centers, we are seeing an increased use of placement of coronary artery stents in the ductus arteriosus to maintain that patent so prostaglandins aren't necessary for the long term, and then they're able to go home and continue to grow as an initial palliation. Once there's adequate growth, either of the pulmonary arteries or of the patient, then you start to see a more, for lack of a better term, definitive repair, or at least a repair that's going to have years of duration, which is where you have placement of a conduit which will go from the right ventricle to the pulmonary arteries, as seen here externally. And this kind of gets to a discussion which we'll talk about a little bit later of, how these conduits are managed over the long term. Another entity that which can also be seen with pulmonary atresia with ventricular septal defect is the presence of major aortopulmonary collateral arteries. And in this situation, you're no longer ductal dependent. These are not patients that require prostaglandins, as they have all of these very large collateral vessels that feed the pulmonary arteries coming off of the descending aorta. As a result, you have a native pulmonary artery that tends to be very hypoplastic and is not connected directly to the heart. So the way in which it maintains any blood flow, because there's no ductus arteriosus, is typically via dual supply connections with some of these very collaterals. And so what you can see here is an angiogram that's taken in the descending aorta, and you can see some of these collaterals. What you don't see in this image is you don't see the native pulmonary artery. But when you take a catheter and go into one of the collateral vessels and inject, you actually can retrograde as it finds those communications more distally. It comes back and there's your native pulmonary artery. And you can see that that's significantly smaller than some of these collaterals. And so the management of this can be fairly different. I've seen a wide variety of either from taking these collateral vessels and patching them into the native pulmonary artery, to growing the native pulmonary artery, determining if the pulmonary arteries fill all the lung segments and closing off the collaterals, or also reincorporating some where there's not what we call dual supply. And so here you have kind of a depiction of a pulmonary artery, and as you get more collaterals, it tends to be smaller and smaller. And so importantly, if you want to try and recruit the native pulmonary artery, it requires doing something to grow that. And so in at least one institution I've worked in, we would place a shunt directly into the collateral, into the native PA to grow it, and then come back and place something like a conduit. So the second disease I'd like to talk about is Truncus Arteriosus. So the definition of Truncus arteriosus is a single arterial trunk that arises from the base of the heart and gives rise to the systemic pulmonary and coronary arteries. It was actually first described in 1798, so you can kind of imagine here's a significant heart disease, and I showed a lot of our modern therapies didn't come until within the last 30 or 40 years. Actually, no, I'm older than that now. I guess 50 years. 50, 60 years. Sorry, I shouldn't have dated myself. And here's part of that first description, which actually describes it exactly as we see it, with the large arterial trunk arising from the ventricle, ascending into the thorax, and giving rise to the pulmonary artery. And this is actually the first image. Do you have the pointers out? Mine died. I'm sorry. Oh, perfect. All right. So you can see here. Here's the ascending aorta, and here's the main pulmonary artery with its branches coming off just after the aortic valve. So this is part of the original description. So Truncus arteriosus represents 4 to 9% per 100,000 live births. That's 1.1 to 2.5% of all congenital heart disease. So 1% of the population is congenital heart disease, 1 to 2% of them with this, so a very rare disease. There are some patterns of familial recurrence, and this is commonly seen in DiGeorge syndrome, and also caused by defects in 10p13. And again, also environmental factors can be implicated. And this is kind of shows some of the embryology and kind of explaining how this happens. And we can see here's the future formation of the ventricles, and here's the truncus arteriosus. So it's something that we all start with. And what we see is we see the arising of these ridges that come in to septate both that truncus arteriosus, as well as will be part of the septation of the ventricles. And then we see as that septates, we get a formation of the ascending aorta as well as the main pulmonary artery. When we see failure of that septation, you can see as that twists and divides, you can see why we will see often the rising of the main pulmonary artery from the area just above the valve where the septation might fail. So when you have failure of the septation, you get persistence of the common arterial trunk. A failure to merge with the coronal septum results in the ventricular septal defect. And this can be associated with maternal diabetes, retinoic acid exposure, or abnormal folate transport. Truncus arteriosus comes in different flavors. This is one classification scheme by Collett and Edwards. Type 1 is typically where you have you actually have a main pulmonary artery that comes off just above the truncal valve and gives rise to the left and right pulmonary arteries. In type 2, you tend to see the pulmonary arteries coming off directly from the ascending aorta without a main pulmonary artery trunk, and they tend to arise very near one another. In type 3, there tends to be more separation, seems to come off of the sides of the ascending aorta, and then it starts to get into other classifications, type 4, and some people with some controversy over what type 4 represents. Van Praag, another anatomist who has described this, again, a lot of similarities with type 1 and type 2. Type 3 starts to look a little bit different than the type 3 that I showed, where you have the left pulmonary coming from the underside of the arch, and then also with type 4 taking on some even additional changes. Here's some anatomic specimens. You can see, so here's your type 1 or A1, and then here you can see the main pulmonary artery coming off of the ascending aorta. Here's a type 2, and again, here you can see the two branches coming off very nearly side by side. And yes, I think we can all see a face starting to form in some of these. And then here's a type 3 or A2, and yeah, that one is a little bit creepy. I apologize. So, all right, and then a type 4. So the truncal valve is usually committed to both ventricles. There's some variety in the number of leaflets that valve will have. A lot of people are tempted to say that when asked how many valve leaflets are in a truncus arteriosus, a lot of people want to say the most common is 4. It's actually not, it's 3, which is a normal number. 4 is actually the second most common, but that's usually what people think about with truncal valves is the quadricuspid trunk. The truncal root is often dilated. It may be stenotic or regurgitant, which presents further problems with leaflet dysplasia or being nodular, and there can be problems with the commissures, and it's typically in continuity with the mitral valve. The aortic arch, commonly, about 20 to 35% have a right aortic arch with an interrupted aortic arch in up to 20%, which is more associated with the George, double aortic arch, a persistent fifth arch. And just some of the other abnormalities, single pulmonary artery, stenotic pulmonary arteries. And then you can see, it's common to have an absence of adductus arteriosus, although you can see adductus in some settings. And then if there is one, it often will persist in as many as 2/3 of these patients. There's also some coronary artery abnormalities. See, I'm running out of time, so I'm going to proceed here quickly. Often there's pulmonary overcirculation. It can be actually quite significant. They become cyanotic with a wide pulse pressure, again, for many of the same reasons that we saw this in pulmonary atresia and ventricular septal defect. And then, so just here's some of the findings. You can kind of see this is just kind of shows superimposed the truncal valve. I don't know that it's quite as obvious on this. You can see, I'm going to show I think the image that really shows it well is here you can see the main pulmonary artery in a type 1 coming off with the ascending aorta. Without intervention, they're going to develop Eisenmangers very early with pulmonary vascular disease, systemic hypoperfusion, so they can become very, very ill without intervention. Usually there's not a place for banding the pulmonary artery. Really, the complete repair is done straight away with a RV to PA conduit, so again, kind of along the same theme that we talked about. And this just kind of shows that surgery where they remove the pulmonary artery from the ascending aorta and sewn in a conduit here, and here you can see that repair with the different types of conduits that can be used. Here's some different other of our furry friends that can also find Truncus Arteriosus. And then just for very briefly, I'll just show some of the discussion there was on transcatheter pulmonary valves, something that's been available to us for about 10 years now, and we now have multiple valves. We have the Melody valve, the Edward Sapien valve, and then we have some other valves that are coming into development, ones that are going to be more appropriate for native outflow tracts like in a tetralogy of Fallot type, but for those with conduits, we have already multiple options. And again, as we've talked about, tetralogy of Fallot, pulmonary atresia, Truncus arteriosus, all very common diseases where we can see indications for this. And this just shows an example. This is actually in a native outflow tract, so more of a tetralogy patient. Placing of a stent to begin with, and then placement of the pulmonary valve. Looks just like placing the stent. It really has a lot of similarities. Only the nice part about this is when you're done, all the contrast stays in the lungs and it doesn't go back to the heart, and you have now a competent valve. Here's actually what we normally see in kids with conduits, so it obviously looks very different, very narrowed, and doesn't look good at all. So we start off by dilating it and kind of resuscitating the conduit as best that we can. And we follow that up by placing stents to reinforce that, and placing the Melody valve in this case. And then afterwards, again, the pleasure of seeing a competent valve. This is just an example of the Sapien valve. Looks very similar. It's a bit shorter, but again, with the results that you desire of having a competent valve without having to go through surgery, because the one problem is these conduits don't last forever, but we're getting better at making them last longer and longer. And so, with a success rate of greater than 95%, these patients going home the next day, anyone that's had a conduit replacement knows you don't go home the next day. So this has really been a great advance in our field. Don't really have time to go over this. It's just an alternative approach that we used in a patient that really couldn't have a normal valve, because despite an enormous balloon that was as big as the largest valve available, we still had flow going through. And so after doing some work and creating a model, so something that was done here at Methodist, We actually banded the pulmonary artery to make it small enough to accommodate the valve. So we did have to do open chest, but not open heart. So on the beating heart, we were able to deploy, and this is just a string that we could put in so we knew where we were, and then placed a melody valve, again, open chest, but closed heart, and allowed her to go home in a couple of days. Again, now with a competent valve. So in conclusion, we have, as we're showing kind of increasing severity and complications of disease, we are able to do more and more for these patients using less and less invasive techniques. Thank you.